For the Lawrence General Hospital Case of the Month for April of 2017, we have an 88-year-old male who came into the emergency department with chest pain that radiated to the back. The pain was sudden in onset, and the ER provider was really concerned for aortic dissection. So once IV access was established, the patient was taken emergently to CAT scan, where a CT angio was completed. The CT angio was negative for dissection. Though the contrast wasn't timed for this, there was no pulmonary embolism. There was no pericardial effusion seen on CT, there was no pneumonia, and based on the CT results, the cause of the chest pain remained unclear. Blood work was done, patient's vitals were relatively stable, and the patient was admitted to the ICU. The intensivist came down and assessed the patient and thought maybe this was worsening COPD, maybe this was ACS, though, as I said before, the diagnosis wasn't certain. 30 minutes later, the patient started to get worse, and the blood pressure began to fall. Once the provider realized that this patient was no longer stable, she started vasopressors and right away to the point-of-care ultrasound. This is a cardiac ultrasound, and this is a mix of both the parasternal long view and parasternal short. And I hope something's jumping out at you right away, and that's this anechoic finding here that's concerning for a pericardial effusion. When you look here, this is another parasternal long view at the RV, it seems that the free wall here is bowing in to the right ventricle. It almost looks like that there's an invisible man jumping on a trampoline or jumping on this RV, and that's concerning for tamponade physiology. The ER provider did an IVC ultrasound, and as you can see here, doesn't seem to move at all with inspiration and is completely plump. And this is also concerning for tamponade physiology. Once the ER provider knew that there was a large pericardial effusion causing tamponade, she then measured the aortic root and found it to be dilated at about 5.5 centimeters. Knowing that there was a dilated aortic root and a forming pericardial effusion that was not seen on CT, so this must be forming pretty rapidly, there was still concern for aortic dissection even though the CT was negative for dissection. With this, the ER provider and the intensivist contacted cardiology, who came in to do an angiogram in the cath lab. And it was on the angiogram that they found the diagnosis of aortic dissection, type A. Without this ultrasound, without the persistence by the ER provider, I think there's a pretty good chance that this diagnosis would have never been found. And this case just illustrates how helpful ultrasound can be at the bedside.